I'd like to do a brief introduction before that. So, Professor Dr. Cesare Piazza, currently Professor of Otorhinolaryngology and Chief of Department of Head and Neck Surgery, University of Brescia, Italy, since September 2020, completing MD degree at University of Pavia, Italy in 1996. He completed his residency program in Indian Head and Neck Surgery in Italy in 2001. He has been the chief of the Department of Otorhinolaryngology, Maxillofacial and Thyroid Surgery, at the National Cancer Institute of Milan, University of Milan from June 2017 to 20. Proficient in head and neck surgeries. He is the president of European Laryngological Society since 2021. Authored and co-authored more than 180 papers in peer-reviewed journals as well as 78 book chapters. He is the editor of Current Opinion in Otolaryngology, Head and Neck Surgery Journal for Head and Neck Oncology since 2010 and is member editorial board since 2013. So over to you, sir.
Okay. Do you see my slides?
Yes, sir, we can see this.
Perfect. So thanks a lot for your kind invitation to be part of this webinar. I enjoyed it so far, and I think it will be definitely a very interesting event. And thanks to the coordinator of and the organizer. They are all good friends. I've seen them in the audience, and I hope to see and meet them again soon. So the topic of my lecture is the tracheoesophageal puncture related complications that are a topic that I will try to discuss with you, especially in relation to how to prevent these frequently difficult to be solved issues. Just a quick introduction. As you all know, the success of total laryngectomy cannot be no more considered only from the point of view of the oncologic results, but we are all forced to consider even functional issues very important for the patient, like the ability to properly communicate again after this mutilating surgery, and to regain to a normal diet per os. For what concerns voice rehabilitation, as you all know, there are at least three different approaches. One is the esophageal speech, plus minus the adjuvant use of electrolarynx, and then obviously the TP, which will be the main focus of my lecture. The TP is aimed at positioning one-way valve voice prosthesis that create a shunting between the trachea and the neopharynx, so that the patient can maintain a lung-powered voice. And this is the main difference in comparison to the esophageal speech, which has a very limited duration and a very effortful production. By contrast, the TP allows the air to be forced from the airway to through the shunt into the neopharynx and to be articulated by the vocal tract composed by the oropharynx, rhinopharynx, mouth, and therefore the outcomes of this technique are definitely a longer phonation time, better intelligibility and fluency in comparison to both the esophageal speech and the electrolarynx. This is, I would say, something that nowadays has been definitely concluded. As well as you will know that the TP can be positioned both as a primary procedure just at the end of total laryngectomy during the procedure itself through the open neck and open pharynx, or as a secondary procedure in another short general anesthesia, usually not lasting more than 10 minutes, months or even years after total laryngectomy and the end of radiation or hemorrhadiation needed. Interestingly enough, if you look at the literature, the first description of this procedure in 1980 by Singer and Blom in the annals of otology, rhinology, and laryngology was referred to a secondary TP. Okay, and then in the following years, these same authors recognized that this technique was fully applicable also in the primary setting at the end of the total laryngectomy. So nowadays we know both techniques and we differently apply them according to our needs, but at the beginning this was just a secondary procedure. From the success rate point of view, there is no difference in between the primary and secondary TP. If you look at the literature, and this is a very good systematic review that I suggest you to look at, you will see that the success rate for the primary and secondary procedure are very similar, in between 65 and 85% for both techniques. So this is not a matter of success rate. The matter for choosing one in front of the other are related to different issues. First of all, primary procedure definitely is easier because you have already the neck open in your OR, and it's very easy. It's a 30-second procedure to insert it through the open neck and open hypopharynx. And you spare second general anesthesia, you spare money, and you have a good psychological impact on your patient that just few days or weeks after the primary procedure is already able to speak and to communicate with his relatives. On the other hand, obviously you put all your eggs in the same basket. So if you have got a complication at the level of the pharynx, like a fistula, or at the level of the neck, like bleeding, or a chylus leak, then obviously you have a higher rate of failure or complication even at the TEP side. So you have to properly select your patient accordingly to the type of surgery you need to perform. And we will talk about this. I prefer to put a secondary TP in a patient with previous radiation, previous chemoradiation, large resection of the hypopharynx, esophagus, and or trachea, radical neck dissection, all situations in which I fear to get an high complication rate, and I am not inclined to risk to increase the complication rate even at the TEP site. Obviously, if you want to make a secondary procedure, you have to discuss with your patient that you will need a secondary general anesthesia, but this is not usually a problem. If he survived already to a long procedure, 6-8 hours with reconstruction, like those that are usually my favorite choice for secondary TP, there is no matter to do a second general anesthesia some months later to put the secondary TP. So apart from the type of surgery, the choice between primary and secondary TP is based also on the patient characteristics and motivation, pathological history, comorbidity, frailty, and obviously all these things are part of the patient selection. Sometimes they not only guide you in the choice between primary versus secondary TP, but even in the choice in between TP and no TP, because, for example, old patient that lives alone without adequate social support, without adequate dexterity, with neurological comorbidities or other issues are not good candidate in my view to receive a TP for a lot of reasons that will be discussed later. So, and when you choose a patient as a good candidate for a TP, please consider that positioning of the prosthesis primary or secondary is just a small fragment of your work. It's very easy to put a prosthesis. It's less easy to take care of the patient as long as he will survive. To change these prosthesis every 6 or 9 months, you have to build up a relationship, a strict relationship with him in a dedicated office, and you have to take care of, obviously, also of complication that we will describe soon. So patient selection is fundamental. It's fundamental to avoid or reduce the complication rate, to be sure that you will reduce to a minimum the rate of closure of the shunt. We will discuss at the end of the lecture. There is some patient that after a certain amount of problems, they want to get rid of this TEP, and it's not easy. Okay, it's possible, but it's not a minor procedure. And so you have to select properly from the beginning the correct candidate for the primary or secondary TP. If you are planning a secondary TP, please be very careful in the preoperative evaluation of your patient. You have to know exactly, if you have not operated him or her, you have to know exactly what kind of reconstruction was done at the level of the neopharynx, if it was primary, or with a free or pedicle flap, and which kind of flap, and then you have to see if the pharyngeoesophageal segment is normal, or there is an hypertonicity or spasm or cicatricial stenosis, like scar band, that are all contraindications to a secondary TP. And this obviously can be done by various oral tests or video fluoroscopy very easily. And then, if you are indeed planning a primary TP, please pay attention to some small details that can make the difference in between a good stoma with a usable TP or a bad stoma with a non-usable TP. Some of these details have been already given to you by the previous speakers. I will just mention very basic and quick tricks that in my experience are well functioning. The stoma must be the largest possible because in the following months, especially after radiation or chemoradiation, it will always shrink a little bit. So if it shrinks too much, you will have a stomal stenosis, and you will have also difficulties in changing the prosthesis. The larger stoma has been obtained in my hands by suturing the tracheal wall on the inferior skin flap of the sternal part of the wound from 180 degrees, stretching laterally, as described before, the tracheal stump, and suturing in a beveled way the posterior wall of the trachea to the posterior apron skin flap in order to widen the posterior part of this stoma, putting attention in not having a devascularized, too long beveled posterior wall. Otherwise, you will have obviously adhesions of the shunt and obviously a lot of problems. Then you have to cut the sternal heads of the sternocleidomastoid muscles in order to flatten as much as possible the stoma and make it possible to occlude it easily with the tongue during the phonation. And then you have to precisely choose the position of your shunt, putting it not too low in the stomach, but maximum 1 centimeter from the mucocutaneous suture at the level of the posterior wall. And then obviously you have not to use too much stitches. I prefer the 2-0 silk, but it's equally good the 2-0 vicryl, and I usually not put more than 4 or 5 stitches in the tracheal wall, anterior tracheal wall, and no more than 4 stitches in the posterior tracheal wall, in order not to exacerbate granulation tissue and stenosis. Then there are a number of other factors that can improve your TP voice, but that are usually not under your surgical control. For sure, the primary closure of the neopharynx when feasible and when good is the best option, because the vibration of the mucosa of the neopharynx is the best thing you can have in order to voice quality. But when you have got a failure of radiation, chemoradiation, or an extension to the hypopharynx, esophagus, and so on, or base of tongue, then you need a flap, and you are not always in a good situation to choose the most adequate flap. But the rule is that the pre-flap has a better voice than the pedicle flap. The fasciocutaneous flap has a better voice than the myocutaneous flap. And the thin flap, like radial forearm, has a better voice than the thick flap, like ALT or rectus abdominis or lat dorsi, or whatever kind of flap you can use instead of the radial and ulnar free flap that are definitely the thinner free flap we can harvest in our body. Because obviously the amount of vibration becomes lazy when you have got a very thick flap in reconstructing your anterior wall or the full circumference of the neopharynx. Then the problems that you can encounter after a TP are a lot. The most frequent one is the fluid leakage that has been already described by the previous speaker, can be through the voice prosthesis or around it. When it's through, it means usually that the vulva is old and must be changed. And usually it happens around 4 to 9 months after the previous change of the TP. This means that the valve is old or has been colonized by Candida or other fungi, and you have to change it. And usually changing it, everything is okay. When the leakage is surrounding the stoma, this can be the same issue, and the first attempt must be always to change the valve, but sometimes you may have other issues because for example, the shunt is becoming too large or adjacent, and then you can change the size of the TP, and sometimes this can be enough, but sometimes you may have persistent troubles. And same for granulation tissue that is usually associated. It may be a very easy problem, not at all an issue, because the granulation is very small, but sometimes big granulation or 360-degree granulation can become a problem to change the valve in the office, and if they bleed, they need bipolar cauterization, even to shrink them and to allow easier change of the TP. Displacement of the prosthesis is an emergent situation. If it goes through the esophagus, it's very rare. It's not usually a problem, but if it goes into the bronchi and lung, they must be removed through a bronchoscopic approach. And severe crusting, much more frequent after radiation, is usually to be prevented by using a humidifier, especially for patients living in very dry environment. And obviously, all these problems are much more frequent in patients that have been received radiation or chemoradiation. These are some pictures related to fluid leakage, granulation, case of dislodgement of the prosthesis into the lung, and severe crusting. Please consider that these complications are not rare. Okay, they happen soon or later in about 1/3 of your patients. So this is the reason why I always stress for the adequate selection of your patient before a TEP, primary or secondary as you prefer, but discuss with him or her a lot before this, because when they have got problems, then they can be sometimes difficult to be solved. There is an interesting systematic review in which these authors found a lower risk of fistula leakage and other complications in secondary TP. This is an argument in favor of TP, secondary TP. And in fact, if you think about the setting of a secondary TP, apart from the secondary general anesthesia, second general anesthesia, and a little bit sometimes tricky situation if you have got a free flap, to choose exactly the position in which to make the puncture through the stoma, but it is usually the best scenario in which putting a prosthesis, because with the adequate experience, you always get the best outcomes, because everything has been already settled down, the radiation therapy has been already delivered, the patient has been through the worst period of his life, perhaps, and now is highly motivated to get this voice prosthesis. When you do the primary procedure, by contrast, you have all these troubles to be still solved, and sometimes these troubles can impact on the fistula success rate in terms of leakage, bad positioning, and so on. So always consider these potential changes. But unfortunately, so far, the device lifetime is still one of the major limiting factors of the TEP use, because whatever the trademark, whatever the material, whatever the toilet that the patient may, even when even when he is very compliant and he is very scrupulous in assisting the toilet of his prosthesis, sooner or later this will be colonized, and in 9 months, maximum 10 months, 11 months, it will be insufficient. It will have a leakage, and it will have to be changed sometimes in a semi-emergent scenario, because the patient cannot drink, cannot swallow anymore. It starts having fever, small aspiration pneumonia, and therefore you have to change it quickly. Obviously, this after radiation therapy, the lifetime of this device is shorter, because colonization is easier. But don't worry about the sudden worsening of voids and mucositis in the surrounding the TEP prosthesis during radiation, if you have put a primary TEP, because this always happens, and this is usually nothing very serious. After the end of radiation, after 1-2 months, everything will be okay again, and you don't need usually to change sooner the TP. after radiation. You have just to wait for the waning of the post-radiation effect. As you all know, as I mentioned, radiation can be a limiting factor for the lifetime of TP. And primary TP may have, for this reason, a longer first-time prosthesis lifetime. And when needed, however, as you all know, the change of the TP is an office-based procedure, very quick, but it must be frequently performed in few hours, not in 1 week or 1 month. When the patient call you or their relatives call you, you have to change it the next day maximum, because it is becoming a serious problem. And again, in special situation, you have not to replace straightforward the prosthesis, especially when there is a prosthetic leakage or big granulation tissue. This means that perhaps if you put straightforward another prosthesis inside, you will have the same bad outcomes, and therefore you have to leave the shunt without the prosthesis for some days. For example, passing a nasogastric feeding tube directly through the shunt from the tracheostoma into the esophagus, and feeding the patient for some days through that feeding tube, and to bipolarize and leave the granulation tissue healing properly, and then reinserting again a few days later another TP. If again you have a prosthetic leakage, again you can try with the stitch to make a sort of tobacco pouch surrounding the shunt and the stent and the prosthesis, or to inject hyaluronic acid in order to reduce the leakage. Sometimes, whatever you are trying and whatever you are doing, problems are not solved, and the patient gets annoyed by the situation and start asking you to close definitively the fistula. It's definitely not a minor procedure. You cannot put a stitch through the fistula, because this is a real fistula and a real tracheoesophageal fistula, so it will never close with a simple suture. In the literature, you can find some option like this: silicone button put through the shunt, temporarily or definitively. I don't like them. I think that they are just a temporary solution. I've seen them dislodging in the bronchi, or creating even larger shunt with granulation tissue, and therefore worsening the situation most of time. So when I've got a patient that wants to get rid of this fistula, I always plan a bipedal radial forearm skin flap, faciocutaneous free flap, with one pedal suture to the tracheal side and the other into the esophageal side. The anastomosis are usually easy to be done with the superior thyroid artery or inferior thyroid artery and superior thyroid vein, or enthuside with the internal jugular vein. But clearly, as you know, it's not a minor procedure, and in good hands, it's nearly, I would say, 100% success rate. But if obviously your not always a very easy and smooth procedure. In good hands, there are reports in the literature that consider it a very good tool, reconstructive tool, but again, I prefer to prevent this situation than to treat it because, as I mentioned, a good candidate selection for TP, a good performance of the primary and secondary TP, and a good management of possible frequent complications are always the key success tricks to avoid this final situation. Thanks for your attention.
Thank you, Dr. Piazza. So, questions from the audience?
The only question problems of the DEP, when the puncture becomes wider and bigger, especially after radiotherapy, and starts a peritubal leak, and the prosthesis has to be changed frequently. And if the patient no more interested in TEP because of the swallowing issue, how to reconstruct the TEP puncture? And I think that is the one.
Excuse me, I don't hear anything. Is there any question from the audience?
Sir, yeah, there is a question.
Okay.
Can you hear us?
So, hello? Hello?
Sir, we'll have to touch on here.
Now, my question is, especially in a post-irradiated patient, if they come for the DEP and change of DEP, if the puncture becomes wider and wider because of fungal infection, granulation, other complications, if we develop other complications of DEP like peritubal leak, fistula, and if the patient is not interested anymore for the prosthesis because of these complications he has faced, what's the method of reconstruction and accurate method of reconstruction of the puncture and we can go for some other method of speech communication.
So, if I understood well, you are asking how to close a fistula after a repeated complication, no more amenable in a conservative way.
That's it, definitely. That's my question.
Okay. So, as I showed you in the previous slides, my favorite option in this kind is to harvest the radial forearm free flap with two pedals. Usually, you don't need a large skin pedal, just for example 2 centimeter maximum for the trachea and 2 centimeter maximum or even less for the esophagus with an interposed deepithelialized bridge. You suture one skin pedal to the tracheal wall, you fold the radial forearm and you suture the opposite skin pedal to the esophageal wall. And then you put the pedicle in the neck and you make your vascular anastomosis. If you are not if the situation of the neck is terrible, you can also put a salivary stent if you want into like a Montgomery salivary stent to reduce the risk of persistent salivary fistula. And I personally remove it. When I put it, I remove it 45 days after this reconstruction. And then I make my anastomosis as usual in the neck. And I didn't do, fortunately enough, hundreds of them, but in 4 or 5 patients I needed it, I had a 100% success rate so far.
Thank you.
Have I answered to your question?
Yes, sir. Thank you very much. Yeah. So thank you very much for coming online and giving this wonderful talk. So we'll be sending you a memento via mail to you. Thank you very much once again.
Thank you, Karthik. See you again. See you soon.
See you.